So this is a typical question you may see on the NCLEX because it's GI, very important. How do you approach it? It may be select or apply in a standalone form like this table or part of a case study. Don't worry about it. Bring your content. Forget about the table. It's presented in a fancy form. I can take the table out of it and I will say, a nurse is caring for a 1 day after laparoscopic cholecystectomy client, right? Which finding are expected? That's all. Then you have to pick the answers. It says select or apply. Instead of that, it's the same thing. Which finding are expected and which one are not expected? And this is caring for a client 1 day after laparoscopic cholecystectomy. What did I do? I put the finding in the table and I say select expected, unexpected. And in NCLEX, you see another column, which is expected column and a unexpected column. You can separate it. I just put them together so that it can be easy. The same thing. Then you bring your content. You know your content. You know what you need to do. This is the individual. The gallbladder is right here. It's behind the liver. This is your liver, right? And this is your gallbladder. This is usually removed through a laparoscopy, tiny holes like that. After the surgery, what should you expect? That's all. That's what the question is asking you. And then look at each question and see if it's something you should expect. This is teaching. If you know the answer, you can put it down. But what do you think? After somebody had cholecystectomy, 1 day after the surgery, do you expect them to have shoulder pain? If it is, you select it, expect it. If it's not, yet you don't have to guess. Bring your content. Green, green drainage from the incision. Do you expect them to have green drainage from the incision? If you give them opiate, do you expect them to have nausea, right? Do they have flatulence or bloating after the surgery, immediately after the surgery? Should their feet temperature be 102? Is that something you should expect after post cholecystectomy? And do you expect them to be on clear liquid diet as story-related? That's all. This is classic GI question. So after cholecystectomy, what do you think? Co- Left shoulder pain. This is an expected finding. It should not surprise you as the gas escape, right? So this is an expected finding. If there's a green drainage from the incision, that is complication. It means there is a bile leak. A bile leakage is a problem. So this is not expected. It's a problem. You can change expected and not expected your own word. Sometimes you get confused. People get confused about it. When they give you something like this, if it's the expected and not expected is confusing you, change it into concerning or not concerning. If that's what you think you should, right? So shoulder pain is not concerning, so it's an expected finding, right? Green drainage from incision is concerning, so it's not expected. I don't expect that. If I give you opioid, you're going to have what? Nausea. I'm not worried about it. So this is unexpected. And then after surgery, usually you're going to have bloating and fluttering because you remove your gallbladder. This is an expected finding. Your temperature 102, that is rare sepsis. It's not just 99.9 or 100. This is 102. That is unexpected finding. That is bad problem after this surgery. So this is not expected. What do you think? Clear liquid dye is cholecystectomy. We remove the gallbladder. It's 24 hours. Well, we can let them drink water. Nothing wrong with it. Clear liquid is something you can see through. And this is how you can talk yourself through. Bring your content and answer this table form that they put in the next generation. How many points have you got? 6 points, free of charge. And when you do that, you see that the case study breeze through, right? You select or apply in disguise, but you got to bring your content, right? Bring it and analyze it. So that's what you got. Same thing. which finding require intervention and which one can be monitored. You can change it if it's confusing you. You can say which one is concerning and which one is not concerning. But then go with the buzzword. The buzzword is what? A nurse is assessing a client 24 hours after what? Left-sided ischemic stroke. That means the buzzword is the patient had stroke 24 hours, left-sided, and do I monitor this finding or do I intervene? That's what I'm focusing on. If I have a stroke, left-sided ischemic stroke, after 24 hours, what should I see? That's all. Keep on rewriting your question in your own way. This is test-taking strategy. This is the way adapting case answer question so they become more manageable. Forget about the words they've used in the question. Underline the buzzword, put them together and say somebody have stroke, left-sided stroke for 24 hours. What would I see? Now, difficulty swallowing water. Do you see? You think it's okay after 24 hours of stroke? This is what is going to happen. Right-sided weakness. Do you expect that? Slurred speech. Do you expect that? Blood pressure of 180 over 91. Do you expect that? Sudden confusion and restlessness. Do you expect that? And facial droop. Do you expect that? Right. 24 hours after stroke, if you have difficulty swallowing, your condition is worsening. So we have to monitor it. Okay, we got to do something about it. When we monitor it, we got to intervene. In this situation, we have to intervene because you are in trouble. So I got to figure out why you can't swallow anymore. Remember, when you have stroke, you may not everybody have dysphagia. But if you have dysphagia, that means your stroke is a bad stroke, worsening. So we got to intervene and so that you don't swallow. You don't have aspiration. Right-sided stroke, you have to bring your content. Okay. You see, they put left-sided stroke. I have a bunch of neuro on questions on neuro review on stroke. You have to know this. Your body is divided into two, and your brain does different thing. Your the left side of your brain control your right side of your body, and the right side of your brain control the left side of your body. If you have left-sided stroke, your left side is going to be fine. You have to understand that. So your right body on your right side is going to be in trouble. That's why this is a right-sided weakness. If I change it and I put left-sided weakness, that is an unexpected finding. That's bad. That means the patient is worsening. So a right-sided weakness from a left-sided stroke is an expected finding. So we're going to monitor this. Slurred speech is part of the FAST acronym, right? FAST, slurred speech. This should be monitored. Blood pressure of 180 over 91. Don't get trapped. You will see standalone question. Anybody who have stroke, this is the content about stroke. If you don't know it, this is adapting class. I'm giving it to you. Everybody who has stroke within 24 to 48 hours, their blood pressure should not be normal. If you bring their blood pressure down, you causing them to have more stroke. We call it permissive hypertension. So you can let the blood pressure ride up to like close to 200. You don't want to drop it to 120 over 190. That's wrong. Or 120 over 80. That means that's a bad problem. So 180 over 91 is permissive. It's just 24 hours. So let this blood pressure is needed for perfusion of the brain. Cerebral perfusion is maintained after 24 hours with permissive hypertension. That is the content. Check adapting class. There's some videos on stroke free that you can watch it. So this one we should monitor. Confusion and restlessness means airway problem, right? So we have to intervene. Facial droop is part of the FAST acronym. So this is an we can monitor it. But these are little, you can see I'm using this. I did 3 videos. This is the third video that you can watch. But to show you that these things are nothing, they just taking the content, all the things you know about stroke, they put it in the question, and I create a table and I give you signs and symptoms associated with stroke. 24 hours that you should expect. I put it in the table to confuse you. If they give you a case, you should expect this. And when you see it, you say, Hallelujah. Let me get to it. This is easy. I've seen this before. And then you answer it. And you ace the test. That's all you do. And this is just the explanation. Okay. Same thing. A nurse is assessing a client who is what? 30 weeks. 30 weeks pregnant during a routine prenatal visit. So she went to prenatal visit. So the buzzword here, you have to identify the buzzword. I don't know how you approach question, and I try to refocus you again. Maybe you watch other video, whatever they tell you, you can stick with it. But I want you to focus on the buzzword that help you. I underline 30 weeks pregnant because it's key. It's the buzzword. That's what I'm focusing on. Which finding expected and unexpected. And I rewrite my own question. I said, a 30 weeks lady, what should I see? You see the case, the buzzword, what is being asked you, and then rewrite the question. And then I bring my own content of bags. I have key things I should expect in a 30 weeks old pregnant lady. If I see something I should not expect it, I'm not picking it. Then I'm worried about it. That means it's unexpected finding. That's all. So I know I'm dealing with the 30 weeks old. I know I'm looking for things I will see in a 30 weeks old. The fundal height is 26. What do you think? Should you see a fundal height of 26 in the lady who is like what, 30 weeks pregnant? Should you see leg cramp? She's reporting leg cramp at night. Should that worry you? She's reporting severe itchy of the hand and feels and feet at night. Should that concern you? She's reporting of blurred vision and persistent headache. She's 30 weeks. Should that concern you? A fetal heart rate is 145 beats per minute. Should that concern you? She reports occasional bursting hex contraction. Should that concern you? Then you go back, you said, okay, when you're 36 weeks, okay, this is the umbilicus, this is 20 weeks. 36 weeks, you should be way happier. If you're 26, yeah, and you're 30 weeks, that means there's almost like four. The height of the uterus does not match the weeks. That means you have intrauterine growth restriction. The baby is not growing. That's a problem. Leg cramps at night is an expected finding. But the third one is worrisome. Itchiness, it look benign, but if the lady tell you my hands and feet are itchy at night, that's a bad problem. Intervention. Every time you see itchiness in the third trimester in the lady, that is cholestasis of the pregnancies. That means we got to deliver the baby as soon as possible. They will need some lab work. They check a LFT. They make sure the bilirubin is normal, and then monitor the mommy so that we can have the baby. So thus, even though you say itchiness, hands and feet at night is bad. Blurred vision and headache, it's a preeclampsia. Fetal heart of 145 is an expected finding. Mommy, baby heart can go to 160. And then irregular contraction is all expected. This is something probably you've watched a video about it and you know it, but it's in the table form. I expect you to be able to answer that if you bring that content with you. So this one, we don't expect it. I expect some leg cramps, but itchiness is worrisome. Blurred vision is worrisome. Fetal height is expected, and this is expected. This is the OB. Straightforward. I know you know it. If you You have a question you can ask, you can type it, and I will read it. But this is the key aspect of how to manage to deal with these matrix questions. They are not that difficult. Same thing. I'm using content, right? Which finding require intervention and can be monitored. Then you ask yourself, what is the question asking you? The nurse is caring for hospice clients with what? Metastatic cancer who is in final hours of life. Don't answer the question until you come out with your own. You figure out the buzzword, you figure out what is being asked in your case, and then you analyze it. So let's get to it. This is all being asked. We got to intervene or monitor it. The patient is in hospice. You know he's dying. Another word telling you they're dying. Metastatic cancer is everywhere. And then they give you more information. Final hours of life. That means there's 24, 48 hours. What should you do? These are some of the things you will see, right? So, what do you think? Somebody who is dying, the respiratory rate usually drops, right? It drops. And so this is an expected finding. There's nothing as they're about to die, first increases, then it comes down. At the end of life, this is an expected finding. It goes down, right? So you're going to monitor this, right? That's the key. Now, the facial, the patient is mourning, probably maybe pain. So you got to figure out what is going on. It's comfort measures. So when they're mourning, you may have to intervene and give her something so that you can make her comfort as she go, he or she goes. So you got to intervene. Family is asking if suction will help with the breathing. What do you think? If the family is asking if the suction will help with the breathing, this is an opportunity to teach them. When they having problem with breathing, is because they have this thing, terminal secretion, right? We call it death rattle. They sound like a machine. I mean, they sound, you hear gargling at the back, like they dying, they're choking in their secretion. If you suction them, it's going to worsen it. That's what the NCLEX will trap you. Don't suction them because they're having death rattle. The problem is to give them alternative management. Give them medication to decrease secretion so they will get anticholinergic to help them decrease secretion. That's the content. So this is the opportunity to tell the family suctioning is not going to help, but we may have to give them something. Even so, that one we got to intervene and tell the parents, the family that we can suction, but we'll give them alternative way to help with the secretion. The skin is going to be cold and mottled because they're dying. A dying body, that's the way it look like. And they are breathing, there will be apnea and lung pauses. Those are all expected findings. So this is what you're going to monitor. So these are something you know, but this is in the form end of life care. I have a playlist that you can watch and that may help you. Okay. And then this is the Foley catheter, fundamentals, right? Fundamentals. No urine outputs. What? A nurse has just inserted the Foley catheter, right? Which finding is concerning or not concerning? If you're taking care of this patient and you inserted the Foley, what would you do? No urine output 15 minutes after insertion. Should that concern you? Should you call the doctor? Urine output of 900. Exactly. As soon as you put it in, boom, you get 900. Should you worry about it? It's a small amount of what? Blood, think urine. What do you think after insertion of the Foley? Client is reporting pressure in the bladder. She's getting spasm. Are you in the right place? Right? Are you in the urethra? Yeah, you got to figure out. Catheter draining dark amber urine after insertion. Catheter tube coil on the bed. This is fundamentals. What do you think? Put down your question, answer choice, and let me know if you insert a Foley, what are something you should expect. If you insert a Foley right away, 15 minutes, sometimes there's no urine there, right? Sometimes that's the main reason why you insert it to check if the patient have urine. So 15 minutes, don't worry about it. It's not a bad thing, right? But if you put in and you get 900, that tells you patient is retaining too much fluid. They may need the Foley for a longer time, or they may need some medication after the. You have to be careful how long when you remove the Foley. So this is concerning. You can have some small blood when you set the Foley, small trauma, and that's small blood is not that bad. If they have pressure, you got to make sure it's not kinked or you are not in the urethra, you are not in the right passageway. So this is a concern. The urine can look dark, right? It's because they dehydrated. It doesn't mean the dark amber urine. It's not concerning because you just put it in. That's what you got. But a tube that is coiled and kinking where fluid can retain and then that can have infection. You want to have the draining tube as much as possible. So this is the way it will look like. Okay. And the last one. The last one is tricky. Identify which finding are expected and which are not. And this is caring for a client 48 hours after myocardial infarction. There's some questions when they give you time. When they give you time, be careful. It means it's very important. Patient has myocardial infarction and 48 hours. What do you have? 48 hours. There is a reason why I said 48 hours. What do you expect after 48 hours of having myocardial infarction? Would the troponin be elevated? Would the patient be fatigued? Would the patient have ST elevation? Will you have S3 heart sounds? Will your blood pressure be like this? Will you have some small chest pain when you breathe? What do you think? Somebody have a heart attack. Do you expect this finding? 48 hours. What do you think? Let me know what you think. The troponin will take time for it to come down. So this is not bad. The patient has just heart attack. They may be tired. How about ST elevation? Who can give it a shot? You can type your answer. You have ST elevation 48 hours after myocardial infarction. Do you expect this or not expect it? Remember, myocardial infarction is a tissue, the heart muscle is dead, right? It's infarcted. When it's infarcted, you expect it to recover, right? It takes some time. If you still have persistent ST elevation, that means your heart muscle is still dying. This is concerning. After 48 hours, your ST elevation should not be there. It's bad. If you have H3, that means you have heart failure now. That is bad. And if your blood pressure is low, it means you have heart failure. If you have small chest pain, it may be probably you have pericarditis. That is something you can see in a patient with a 48 hours after heart failure, after myocardial infarction. And this is what it looked like. This is what it looked like. These are content related. Like I said, take the table out and answer it, bring your content, analyze the question, and know that this matrix grade is something you already know. You have it. Don't let the NCLEX steal it from you. Take it away and answer it as if you know it. This is Adapting Class. Take care of it. If you need that on demand, you can just email me at adaptingclass at gmail.com. Or you can go to https colon forward slash www at adaptingclassreview.com where you get our website and on demand. Take care of yourself and keep charging as always. Take care. Bye.